Dear friends and colleagues all over the world, good evening and hello. Welcome to our fourth online special seminar on megaprosthesis associated infections. As promised, we will today focus only on complex cases and discuss it with our faculty, which is accompanying all online seminars. Today, we will also, as previously, discuss with you your comments, your suggestions, and among the faculty also innovative and new solutions. So please use the chat function during the next 2 hours to discuss with us and give your suggestions. The faculty of today's seminar are the same as before. I'm very happy, first, that we have this faculty, and second, that you joined in such a large number this online seminar. I can already tell you now that we are planning for next year on-site workshops and that we will probably have the first one in May 2022 on this special topic, infection in megaprosthesis. Professor Volker Alt is joining us from Regensburg, Germany. Dr. Fabrice Fiorenza from France. Then we have from UK, Professor Lee Jace from Birmingham. And I'm, as an infectious disease specialist, joining you from Berlin. Today, we will start with two cases which are excellent for discussion. One from Oslo, Norway, the other from Durban, South Africa. And if the technique will work, the presenter will be both from the two countries. And then we have prepared for you additional cases, which we will then discuss until 20 p.m. Your questions and discussions you can add in the chat, as mentioned, as well as for German physicians. If you add your EFN number, you can claim the 2 credit points from the German chamber, medical chamber, but you can also use the certificates in other countries to get credit points if the medical chamber will accept it. I would also like to mention that we updated our pocket guides on different topics, including periprosthetic joint infection. The German one is already the new version online, and you can download it from the PRO-IMPLANT website for free. And the English translation of this version 10 is coming in the next 2 weeks. So with this, I would like to present a short summary of the first 3 seminars which we had. The first one was entitled "What Can We Learn from Complex Cases?" And we started the discussion from a micro problem, namely the biofilm, which then interacts with an implant and form a biofilm on the surface, so that we optimized and adapted the diagnosis, the antibiotics, and the surgery to target the biofilm and to achieve the highest possible cure rate. We discussed a lot on cases how we can achieve the cure with a proper surgery, with sufficient debridement, and a combination of systemic and local antibiotics to avoid antimicrobial resistance and persistence and achieve a cure. In the next episode, we discussed about the different treatment concepts. All of them are interdisciplinary, so we try to get together the most optimized treatment concept, which was first to decide, is it an acute or a chronic infection? In the acute infections, which were early after surgery, we try to retain the implant and treat with biofilm active antibiotics. Whereas in chronic infections, we discussed between different options, including the one-stage and the two-stage exchange. So this concept, which was developed for normal prosthesis, can be adapted to some extent also to megaprosthesis, where we have either a young biofilm and we can retain the prosthesis, or we have an old biofilm and we need to exchange the prosthesis. So many details which are important for success. And lastly, also the antibiotic treatment, which targets the biofilms, and with sufficient duration, we can eradicate the biofilm. In the last episodes, we thought about rational background. So we went into the microbiology, which pathogens are causing infections, including staphylococci, streptococci, enterococci, and gram-negative bacilli. And dependent on that microbiology, we discussed about systemic and local antibiotic treatment. So this means that we didn't forget also the importance of local antibiotics, both in cement and in resorbable materials. And today we will discuss also in these cases how should be used and in which situations. With this, I would like to invite the first presenter. It is a case of osteosarcoma of left femur, and I hope we can see now Ole Jakob from Oslo to present the case. So I see that it works. It's perfect. Ole, I think, yeah, we can hear you very well. I would really like to thank you that you prepared this presentation. And now the stage is yours.
Thank you very much. I just first have to thank you for letting us join this session. Unfortunately, we have not been able to join the previous sessions, so we've not heard the nice speeches that you made a summary of. But I would like to present a case today. I was a boy, 8.5 years old, who came to us with an osteosarcoma in his left femur. He came to us in September 2017 with this X-rays, and it was soon clear to us that this was a quite large osteosarcoma with a quite large soft tissue component. As we can see, the soft tissue component was extending into the quadriceps muscle. But we performed a biopsy and started chemotherapy. During the chemotherapy, he suffered from a pathological fracture. We can discuss that later, but as you see here, we did an open biopsy in this case. Later on now, in the last 3 or 4 years, or 3 years, we just do needle biopsy. For one can suspect the open biopsy to maybe be part of the problem for this fracture. Nevertheless, it was a minor trauma, and a pathological fracture is not that uncommon in osteosarcoma patients. With a brace on, he continued the chemotherapy, and then in January 2018, we had the pre-op evaluation. And again, as you can see, we had a nice chemo effect with nice ossification of the soft tissue component of the tumor. The tumor, or the fracture, was not consolidated, or so he had the brace on for the whole time. Then in January, and he, of course, he had no meds. So we continued on, and in early February 2018, we did a distal femur resection and made a reconstruction with a Mutage expand prosthesis. Was surgery that took about three hours, and we had 400 milliliters of blood loss. And we used prophylactic antibiotics, 1 day treatment with vancomycin and cefalotin. Then during the spring of 2018, we started the lengthening procedures, and that the mechanism worked well, and the lengthening was no problem. But the boy himself, he had a problem with adapting to his new knee and new prosthesis. He was quite afraid and was not very eager on training. So he almost had a stiff knee. And was not weight-bearing too much. This was quite a hard problem, so we had him at a rehabilitation center during the summer of 2018. And by the end of the summer, he had a 2 or 3 weeks history of pain and redness, along with the or what do you call it, the button for the sensor for the extension mechanism. So the circle we see here is where the sensor for the extension mechanism is located subcutaneously. Then after 2.5, 3 weeks, there was a spontaneous fistula, and it was obvious to everyone that this was an infection. He had normal blood counts, no fever, but just pain and swelling. That was his main symptoms. So then we sat down and thought, okay, now what? And then I don't know if you want me to just continue and present the whole case, or if you want me to stop here to have comments. I don't know what you want.
At this point, probably you can continue. Till now, no comments.
Okay, sure. Then we'll just continue. Well, what we did was we did a revision and removed the implant and started for a 2-stage procedure. We regarded this as an late acute infection, but still we wanted to do this as a 2-stage procedure. Remember, I told you that this boy was not using his left knee and leg. He was not weight-bearing, and he had almost a stiff leg. And there was not much muscle left in this thigh either. Due to both the soft tissue component and the pathological fracture, we were only able to spare his rectus femoris and part of the vastus medialis. So we started to talk with the boy and the family, and we had 3 options. We were discussing with him an amputation. We discussed him doing a new tumor prosthesis implant. And then the third option that we ended up with in this case. So we did a rotationplasty in January 2019. The boy needed a couple of months to get adjusted to this. We started to inform him and his parents, and work with them, with the physiotherapist and the prosthetic guys, so that he was well prepared for what he was saying yes to. So in February we did the surgery. And as you see here, we also took out a part of his fibula to enforce the osteosynthesis and perform this rotationplasty like this. It all healed up very well and quite fast, actually. He stayed in hospital, or these were the pictures after 10 days. The wound was healing well, and he stayed 4 weeks in hospital training with our physiotherapists and doing the preparations for having a prosthesis. So after 6 weeks, he had his orthosis. And that's part of this, or that's our story about this 8.5 years old boy that first went through 9 months of heavy chemotherapy and a large surgery, and then tried to use this or train with this prosthesis for 4 or 5 months until he suffered from this infection. And one of the lessons that we took home after this boy is that maybe we should have thought about a rotation plasty earlier, or at least the kids deserve as few surgeries as possible. Thank you.
Ole, thank you very much. I invite now the faculty to join and give some comments on this case. I can already start maybe from the not surgical standpoint. You mentioned, yeah, it was a late acute infection. But it seems it was at that time a chronic infection already. So I think it was a good choice from infectious disease standpoint to treat it like a chronic infection. But I'm curious now what our faculty will say. Maybe Lee, would you like to start?
Hey Ollie, nice to see you. Great case. Well, great for learning anyway. Maybe not as good as you wanted. So I think one of the points for the oncology surgeons out there I'd like to ask is, was the patient on chemotherapy still when they had the infection, or had they already finished?
It was finished. Finished in February, March 2018, and the infection was in August.
So if we imagine that the kid was still on chemotherapy, I think the way to manage it with a spacer is a very good way, because it's important that the child continues their chemotherapy. So if we do get an early infection, which is often related to the chemotherapy, that we give them something that eradicates the infection but allows them to go on with their chemo. And as you showed in your case, you have the time for the patient to think about where they want to go. You know, do they want another attempt at limb salvage, or do they want to go to rotation plasty, which was a very elegant solution to the problem. But I think it's important that for oncology surgeons out there that we remember that breaking the chemotherapy is a big problem, and with infection that can be an issue if they're on neutropenic chemotherapy. So I think going for a 2-stage rather than a more uncertain DARE is probably the correct decision in those cases.
Could I just comment on that? I totally agree with you, Lee, that the chemotherapy is of the utmost importance. But if we experience a infection after the surgery and they still have some chemotherapy left, then we also have had good experience with suppression therapy. Is that what you would call it? I mean, giving antibiotics and keep it running until the chemotherapy is over. Because just doing a new surgery, making a large wound, and do the first of 2 session revisions could delay the chemotherapy as well.
Yeah, that's a good point. You must have a better relationship with your oncologists than we do, because our oncologists don't like to give chemotherapy until we convince them the infection's gone. So I think, you know, if you can have a good dialogue with your oncologist and say, yeah, you know, we're happy that this patient is low risk from septicemia, then that's a very good way to do it. Unfortunately, as often they want to be convinced more that the infection is under control.
I understand.
Yeah, the same situation we have in transplant patients. They always say we want to be sure that the infection is gone before doing any kind of solid organ or bone marrow transplantation. But with suppression, we are quite confident that this can be done. There will be no breakthrough infection.
Yeah.
Volker, maybe your comments on that case?
Yeah, thank you very much for presenting. I think this was a great case, and you did a great management, and you saved the patient's life, which is the most important thing in such a case. One of the critical things for me in that case is the decision whether it's an acute or a chronic infection. Because if I remember that correctly, you did the surgery in February, and the patient got back with infection symptoms in August, right? So this is half a year later. But from the wound I saw, it looked, or from the leg I saw, it was quite red. You said that the patient also experienced some fever. So no fever.
No fever.
But it was pretty red. So redness is also a kind of acute symptom. So for me, a point of discussion would have been, or is, would it have been possible to try an implant retaining strategy, meaning a DARE procedure with a good debridement with antibiotics and an implant retain, in order to save the prosthesis and to save the entire leg, which is an additional surgery for the patient. As you said, I completely agree. Kids and also adults deserve one-shot surgery or a limited amount of procedures. But I think in such a case, even if the patient was not too motivated, as you said, that he got a stiff knee and so on, I think that maybe with a joint puncture and the identification of the microorganism, if this had been a real virulent Staph aureus, which would have not fitted to a real chronic situation, for me the discussion would have been, can we try a DARE procedure with implant retain?
To dare or not to dare? That's the question. Yes. And if you are not sure, I think suppression after this dare, even in not completely acute infections, could be an option indeed.
Because with the two-stage and the rotational plasty, this is definitely a different solution compared to the tumor prosthesis. And I think that we do not really know what's the real time that separates acute from chronic. And in such a case, with one DARE procedure, it would have been worthwhile a try, I guess. And if this would not have worked out, we still would have been able to do a rotational plasty.
Maybe Fabrice, your opinion there, or
yes,
two-stage?
same type of comment. I would have, I think, discussed a DARE in these situations. Now, if you had not finished the chemotherapy, of course, two-stage with a cement is I think a good idea. But the rotation plasty is a wonderful idea to salvage an infected prosthesis, and so I think I would have talked to the family and for a DARE. But I agree, it's a difficult decision to take. And once you had the spacer, I think the decision to do a rotation plasty at this stage is interesting too, because when you go for a two-stage, in your mind, it's to go back with a prosthesis. I think it's very interesting to show that we can consider a rotation plasty as a second stage in this situation. The other thing I wanted to comment on is he had 1 day of prophylaxis.
Yes, at that time we had just 1 day.
So, well, we discussed this with our infectiologist about 15 years ago, and we decided 15 years ago to do the parity protocol, which was not started yet, and we gave systematically for these patients, risky patients, surgery, long surgery, chemotherapy, 5 days of cefazolin. But I don't know if it would have changed, of course, anything. But this is something we do for these risky patients?
We changed our antibiotic regime 1st of January 2020, and now we use for 5 days. Before 2016, we also gave 5 days, but then just cefalotine and not the combination with vancomycin. And we're trying to keep track of our infection rate, and so far we've not been able to do much.
Show any difference?
No, show any difference. We still have the same problem. Yeah.
I just wanted to comment on two things, and I think the first question is a dare or not to dare, and don't forget the patient had a sinus, so I'd be interested to know whether the faculty think that a dare with a sinus is still something that is reasonable to do. Personally, I don't mind, but in the teachings they would say that if you didn't have good skin that you shouldn't do a dare. That's one issue, and the second issue is about function, and I think what Ollie has shown very nicely is that this patient had 1.5 quadriceps, a stiff knee, obviously wasn't having a good time with the prosthesis, and the lengthening is only going to make the stiffness worse. So I think we have to be aware as orthopedic surgeons that we like a nice x-ray and to stand and show how everything is, but for the child, something that is going to be durable, one operation after a lot of treatment, probably the child was never going to have great function with the distal femur with just one strap muscle and a bit of medialis. And so I think it's very important that we sit down and talk about all of these problems, not just that there's an infection, you know. And I think it's very commendable that you managed to persuade the child who was a bit reluctant with the prosthesis to accept a rotationplasty. So that takes a lot of hard work. But I think function, expected outcome from their tumor and the patient make a big difference in your decision making.
I think I have another one of my colleagues that want to make a comment.
Hello, my name is Joachim Torkelsen. I work with Ole Jakob. I was just wanting, I think it's always difficult to remember back, and I think part of the situation was also that we put in this spacer to deal with the infection, and that one of the main points for the family was sort of the most secure management of the infection, and then we still had the option to either go still for a new prosthesis or the rotationoplasty. But in this discussion with the family, particularly in relation to a dare in this setting, what would you, and they start asking you about percentages and odds and these things, and you know, how does your patient fit into the literature? What's transferable? What do you think you would say to this family about the results of a dare in this setting?
Maybe Lee, you can mention.
So when we looked at our results way back when, and we don't think we did dares the way that we do dares now, it would have been 30%. I think our current literature, we would suggest that it's probably around about 60%. But don't forget, a dare is the same as a first stage for us. So what would you have done? You'd have taken everything out, you'd open it all up, you'd have debrided everything, you'd have changed every part that you can do. It's not much difference to a single stage revision, huh?
No,
you know, the only thing that you would have retained would have been the stem. It was an uncemented stem, was it?
Yes.
Yes.
Yeah. So you know, you're probably not going to take that out at 18 months. So I think you're right. I think you know, if you're talking to the patients, my optimistic thing would have been maybe 60-65%. My pessimistic would have been 40%, you know.
Yeah, I think we sort of doubled around the sort of 50-50 mark for a single stage, but talked about the sort of 80 to 90 for the plan that we chose. But it's always difficult to know, and we we made a point of having conversations with the boy and the family, both Ole Jakob and myself, separately. I mean, we give them slightly different statistics as you do. You put your interpretations into it. And we talked to them about that beforehand, that this is but we tried to do that as a measure of them getting a sense that there are more than one solution to the problem, and more than one correct solution, if you like.
Absolutely.
More than
would
one.
The others,
yeah.
Would the others like to comment on what they would anticipate for results of a single stage or a DARE procedure?
Yes, I would also have said that it would be a 50-50 chance that there is literature on, but those cases like yours, that's more or less an individual case. And I think I would also have explained to the family that I would try to do everything with one procedure in order to wash it out, to debride it adequately, as Lee said, as for a single stage. But that I would not be able to guarantee. But with this type of DARE treatment, there would have been the option just to retain the prosthesis. For me, the critical part and the critical question would still be that if the patient had already a problem with the prosthesis and he had a bad knee function, with the rotational plasty, he also has to train and to exercise and to adopt that situation and to adopt an external prosthesis. That this is also something that I would not have been able to judge 100% for the boy, and this would have motivated myself just to try everything to retain the implant. Although I agree, Lee, this was your question. The patient had a fistula at least 2 or 3 days later, but the redness and the thing that more or less the first weeks and the first month remained infection-free, this would have still be an argument for me just to try the DARE.
Yeah, I don't think it's a contraindication personally.
I agree with the sinus tract, what both you mentioned, that in the classical one, we always say it's an exclusion to do a DARE. But now we are speaking about megaprosthesis, so that's a different situation. So we use different concepts. And if there is a fistula, then we know that probably there is not one pathogen, but several introduced through this sinus. And therefore, suppression after the surgery would be broader than just the bacteria we find and longer. And maybe in addition also local antibacterial effects. If this is a silver coated implant or this is good in there is no new implant, but you can introduce new local antibiotics anyway. Fabrice, I think you mentioned this also in one of your previous talks, right? The local application.
Yeah.
Would you comment anything on that?
Yeah, I would have given the best chance. So I agree with Lee that fistula is not a contraindication. If you need to do a flap, you do a flap. You do whatever it takes. But one stage is better than 2 stages functionally. Of course, in this case, the function was bad, so that's why I think your rotation plasty was a very good choice.
Okay.
Could I just ask one question from a technical point of view? You used a vascularized fibula across the junction?
No, a
non-vascularized.
Yeah,
okay.
Yeah.
I just wondered if you did that because of the infection or anything, but it was a non-vascularized.
Non-vascularized, yeah.
Yeah. Okay.
But your strategy, talking to the family, was that you do a 2-stage with the second surgery with the rotational plasty. This was your strategy from the beginning, or did you still try to balance another prosthesis versus the rotational plasty?
Ole Jakob is sitting just next to me. I seem to remember that the strategy was really that all these options were on the table right from the start, and that we had lengthy discussions with them right from the start about each of these options, and then sort of got agreed on that now we need to get get all the tissue out, which has the infection, and get control. And landed on the option that we do this first, and then we can still talk about whether we put in a new prosthesis or a rotational plasty. Do you want to comment on that?
Yeah, this boy was really bad, traumatized after all the treatment and the surgery I've been through, and the disappointment of having this infection. So I think he needed a couple of months to get used to the thought of having a rotation plasty. He stayed home, he went to school, he played with his friends, and had actually the best 3 months last 2 years he had with the spacer inside. So he needed a time, and he got back, and then we could talk more to him, and he had eaten and gained weight, and it was a lot of good things about doing a two-stage revision. But as Joachim said, one important thing was that we didn't have to decide right away in August 2018. We could have had the whole autumn to work out the plan and work it out together with the family.
I think this is an important point in such complex cases, that you need to build up a relationship with your patient. This is for all, at least in my experience with difficult infections. You need to see the patient frequently in your outpatient clinic. You need to talk to him. You need to discuss different options. There might be changes in his oncology diseases and so on, and you need to talk to the patient on a regular basis, and to keep in good communication with him, and to be able to make the final and a very good decision at the end of the treatment.
Until which age would you do the rotation plasty?
We did a rotation plasty a year and a half ago, and she was 52. So that's no problem. She's doing fine. So I think this procedure actually was developed for adults. In the beginning, I mean, this was a procedure for great bone loss after heavy infections. So I think it was the Humor Orthopedic Society that brought it back, and now you see it for kids. But we did it on this 52-year-old woman that had great progression during pre-op radiotherapy for a large soft tissue sarcoma, and I used, I think, 10 minutes to convince her that a rotation plasty was a good idea. She said, "Yes, that sounds cool. Let's do that." So sometimes it's very easy. She was keen right away.
And she also learned walking, and
she's getting there. She'll actually be in my ambulatory next or tomorrow on Wednesday, and so that's the first time she had the prosthesis on. So it's going to be interesting.
Excellent. Thank you for your contribution. I think we would really like to work more with you in the future, and your great team. Say hello to all your team in Oslo.
Thank you.
And see you soon. And now I'm happy to go to the other side of the world, to South Africa, and Pakaman will join us from Durban, presenting this case of a tumor prosthesis PJI. I hope the technique will work. It's it seems Pakaman is joining us. We can see you, and hopefully you can hear us.
Yes, I can see you, Prof.
Good evening, and it's your turn, and then we can discuss your case. Thank you for joining.
Yes, thank you very much, Professor, for the opportunity. It's a privilege for me to present this case to you and your audience. My name is Pakamani. I'm from South Africa in the city of Durban. The University of KwaZulu-Natal is also called the Nelson Mandela Medical School. I'm an orthopedic surgeon, and we deal with tumors and sepsis in this faculty of orthopedics. So my case is similar to the previous case. I actually took some very good learning point from my colleagues in Norway from the cases from the case they presented. Let me present my case. This is a case of early infection of the child, 11 years old, who actually presented in May to us this year with a conventional osteosarcoma of the distal femur. This child came to us having traveled for 5 hours. He lives in the border between South Africa and Mozambique. And it looks like he was already biopsied from the lateral side of the distal femur. We gave this child a neoadjuvant chemotherapy as per international protocol, 10 cycles, and we did surgery at the 11th week, at the 11th week, we did an end block resection as well as the tumor prosthesis. But what we did, the tumor prosthesis, we were very resource constrained environment. We don't have the expandable prosthesis for these children. So for 11 years old, we lengthen him for about 2 centimeters so that we can compensate for future growth. But what we noted from the lateral biopsy site was the oozing wound after 10 days of resection. He was not on anticoagulant whatsoever. So the oozing that we saw, it was almost serosanguinous, no clear pus. So then we took him for a DARE procedure, and then we changed the mobile implant. Even when we opened it, there was no clear pus, but there was an obvious hematoma collection. And then coincidentally, in both tissue and blood cultures, we cultured the same organism, which was an Enterobact cloaca complex, which was sensitive to imipenem as well as meropenem. So we commenced IV meropenem as well as the rifampicin for the early infection, and we kept him for 6 weeks on this IV treatment. And the chemotherapy was restarted 14 days post the DARE procedure. Now, the problem is that we know from the international standards that 21 days is a cutoff for restarting the chemo. We're already here almost on day 25 without restarting the chemo. So that was a problem as well. Although after that, our patient improved without any further surgery or swelling, and even clinically, there was a significant clinical improvement. And then our question now, because we don't have a lot of experience of treating periprosthetic implant infection post tumor resection. So our question now is, we have restarted the chemotherapy and we know that the child has a cancer. And on top of it, now we've got a very aggressive chemotherapy, which is immunosuppressive. And we're not sure how far would you go with the antibiotics in this case now. Thank you.
Thank you for the very good presentation. Another child, it seems today we have a pediatric population. I would again ask all faculty members to join the discussion. And it seems that this situation is a different one than the previous. The previous was probably a chronic infection, an acute exacerbation of a chronic infection, whereas this one is indeed an early postoperative acute infection. And you have also a pathogen which explains all the signs of pus and wound disturbance healing. Who would like to comment? Lee, maybe you can start.
Well, the first thing I'd like to say is it's great to see patients having excellent treatment like you've given them. And I have two points. One is the role of the open biopsy in both the cases that we've heard. Do we think that an open biopsy makes infection more likely in a prosthesis? Is it something that we worry about? And in your case, you had to lengthen the patient by 2 centimeters, which puts more pressure on the wound because of local resources. So the one question I'd like the panel to talk about is whether we think that open biopsies have an increased risk of infection compared to it. And the second point is, even in the arthroplasty world, nobody can tell us how long we should watch a wound that is leaking before we become aggressive. The Dutch had a trial to try to see called the leak study, which is worth a read. But there's a complete equipoise amongst surgeons about whether we go in at 3 days, 5 days, 7 days of a chronic wound leaking. And the leak study from Holland showed the same thing. So I think you've treated the patient quickly and expertly, both for their tumor and for their infection, and you made exactly the right call. Now, I would say, as a non-infectious disease doctor, that I would leave the antibiotics going for at least 6 months afterwards, but I'd defer to Andre's opinion on that. And it depends on whether there's an oral option or a non-oral option, obviously. But I think those were my 2 points that I learned from your presentation. Thank you very much.
Yeah, regarding the diagnostic, I think in this case, anyway, the surgery was done, and the best tissue is the intraoperative tissue samples, better than any biopsies before surgery. And regarding the antibiotic duration, I agree with you that here I would go for 6 months, maybe even longer. And but I would not go so long for IV. You mentioned Pakamani, that you gave 6 weeks meropenem. Depending on the susceptibility of this, was it Enterobacter, I think, or Klebsiella? Enterobacter. We could either go for cotrimoxazole or ciprofloxacin. We can see the antibiogram, and then switch earlier to oral antibiotic. And rifampin, unfortunately, has no activity on gram negatives, so was in this case not necessary. So if the patient is still, even without symptoms, I would start with the oral antibiotics, and we can see the antibiogram. I think the picture is frozen from Pakamani, but we can anyway discuss further. Volker, you lost a little contact, but did you see the case? Would you like to?
Oh, I saw the case. I had some difficulties in re-entering the video files. Also from my side, congratulations on the management of the tumor and also on the infection. I think that you have made the right decision to try to dare. It was an acute infection, and as in the case that we discussed before, I think there was worthwhile trying and worthwhile doing. Andre, in the discussion for both cases, do you think that a joint puncture with the identification of the bacteria would have helped in the cases?
In the first case, probably yes. In the second case, because there was an oozing wound, it was clear that surgery was needed, so I would not go for puncture of the joint. But
but we had discussed, for example, also the possibility of using local antibiotics. Would it have made a difference if you had a resistogram of the causing a microorganism before, in order to be able to strengthen your local antibiotic therapy if you want to do it?
the problem with this puncture before surgery is that we miss about 30% of pathogens, which we then find intraoperatively. So it could be also misleading by doing it targetly only. I would go always broad spectrum, both systemically and locally. And if we combine Vanco and Genta, we are broad, and we would cover actually this pathogen as well. So both of you, Lee and Volker, you agreed that there would be the first choice, and I think the best case. Fabrice, do you have any other suggestion?
Yeah, I agree. There with, as you said, broad spectrum antibiotics, and locally DAC, for example, with gentamicin and vancomycin. Talking about biopsy, I agree with Lee. I think if we can do a Jamshidi biopsy with a very small incision, it's better than an open biopsy. Pathologists just need what you can take with a Jamshidi biopsy, so why not use it? And this is what we do. I don't know if you do that in our unit. Just after the biopsy, we give antibiotics, antibioprophylaxis, one shot.
Did I hear right that you used some installation of antibiotics? You did like a Lautenbach technique, or did you just do a DARE?
Oh yes, yeah. We do use Lautenbach, but in this case we didn't use Lautenbach. So in periprosthetic joint infections, we do routinely use a Lautenbach irrigation system, especially in the chronic infection. We do consider it formed part of our armamentarium of management of long bone infection post-trauma or periprosthetic joint infections. But in this case, we didn't use the Lautenbach. We did a DARE, which mobile parts, and we used the local vancomycin.
Johannes, ja?
Okay. So
Ich muss
Richard
jetzt gerade noch
Kite.
arbeiten. Ich melde mich gleich mal, gell?
Richard Kite, I presume you may have had some interactions with in Johannesburg, gave a very nice talk at a meeting I was with. He obviously followed on from Lautenbach, continue his practice, and he had very, very good results with treating EPR infections with the Lautenbach technique, which is just an installation of local antibiotics, but in a way that is possible to do maybe in less resource affluent areas.
Maybe just for people who don't know the technique, please correct me if it's wrong. So this is the installation of antibiotics intramedullary for several days. So it's like a suction irrigation for osteomyelitis. Lautenbach described it not for prosthetic joint infection. And I would be very careful if there is an implant, because the likelihood that you will do a super infection, so introduce a new pathogen from the skin, is very high, and that would be very critical. So I'm happy that you didn't use it, but I'm also happy that you mentioned this technique, which was first described in South Africa, right?
Yeah, absolutely, yeah. So there's quite a lot of work. Leo Whiteside has done quite a lot of work with periprosthetic joint infections. So Richard Kite has talked about treatment specifically for megaprosthesis infections where you have a large cavity. So I think it's I think we'd have to say an experimental technique, but it's a similar principle in terms of they use tunneled lines rather than using just direct installation, as it were. but it's an alternative.
Yeah,
you can use some modern system like the Veraflow, where you really monitor what goes in and what goes out. And I think if you want to do this technique, you should use these kind of techniques, modern techniques, where you know exactly how much antibiotics you give. Because installation, you don't really control the installation protocol.
And maybe one of the modern techniques in the future, which is actually not modern, it's very old, would be to instill not antibiotics, which acts very slow. Antibiotics needs 48 hours to kill the bacteria, but indeed maybe bacteriophages, so viruses, which will eat bacteria within minutes, or something else. That still maybe be a future for this perfusion system. There was one question in the chat I would like to ask Volker, was regarding PMMA beads with gentamicin, for example. I know that many people are using it. I think you are not using it.
I'm using it.
You're using it. In this case, you would suggest in their procedure?
No, in there I don't use it, but I use it in osteomyelitis. I use it in fracture-related infections. I don't use it for there because the problem with the PMMA beads is that you have to remove them, and even you can discuss it. You can put it just next to a long bone, for example, but you can definitely not put it into the joint because it's a metal implant, and this will definitely destroy your prosthesis. The good thing about the beads is that they have very, very good release kinetics because they have a large surface, and the release kinetics and the release of gentamicin and of antibiotics is very good. It's much higher compared to a bulky spacer, and therefore I think the beads still do belong to our armamentarium, but we need to really make a good decision on the indication, and you can definitely not put it into an articulating surface.
And if we speak about the future, would you rather than go now to a resorbable material than non-resorbable PMMA? So do you have better release, or let's say complete release of antibiotics?
Yeah, I mean there is literature out in the classic endoprosthetic world, for example, for the use of resorbable calcium phosphate carriers in chronic infections, for example, in geriatric and fragile patients that do not tolerate two-stage revisions. So you can use the calcium phosphate cements in those specific indications also for their procedures, just to enhance the amount and concentration of local antibiotics in the wound, just to gain some time for very fragile patients for the next 5, 6, 7 months in order just to suppress locally the situation. And in those cases, I think resorbable carriers are of importance also for the future.
So maybe, especially if there is an also osteoconductive or osteoinductive properties, maybe that is better than the beads. Actually, we say if there is a prosthesis, don't use beads because, as you mentioned, that's the place where bacteria can persist as a biofilm.
I mean, if you have a megaprosthesis like a total femur and you do it there, you can easily put 30 beads PMMA alongside of the stem of the prosthesis. You must not put it into the hip or into the knee joint. In such cases, the beads can also be helpful to improve the local antibiotic delivery. And we do not need osteoconductive or osteoinductive properties for our antibiotic delivery products when we do not use it, like for infected non-unions or when we want to stimulate bone growth. This is not the topic, and this is not a problem in periprosthetic joint infections.
Lee,
we only need them to be resolvable.
I think for this case, I think we have to remember that we're talking to a worldwide audience, and we're very lucky in some countries where we can change the whole prosthesis without thinking and put lots of new things in. Presumably, did the patient have to pay for their prosthesis? Does the patient have to pay for their prosthesis in South Africa?
No, the patient doesn't have to pay. Yes, yeah. The patient doesn't have to pay for prosthesis. Yes, yeah.
That's very good, because in some countries you have to pay for your own prosthesis, and so when we say a DARE and we have to change everything that we can do, and if it's a modular prosthesis, we unscrew it. That in the UK that would cost another £10,000, £15,000, which is a lot of money. So one of the papers that I saw recently about infection in megaprosthesis as a cheaper alternative was to consider adding antibiotic-loaded cement to the surface of the shaft of the prosthesis. So if you don't have the option for say DARE for DAC or Stimulan or other eluting absorbable materials, then a lower cost way to do that is to add a coating of antibiotic-laden cement with the correct antibiotics to the shaft of the prosthesis.
And Lee, maybe in addition to this, would you like to comment also VAC use? It was not used, and I think we do not recommend it, but what is your opinion on that?
So I think VAC dressings or vacuum-assisted dressings are the devil or the saint, depends on how you use them. So if you have a chronically leaking wound and you just put a VAC on it, that is the worst use of a VAC dressing known to mankind. And in this case, I certainly wouldn't leave the joint open and put a VAC inside the wound. But I think once you've done a thorough debridement, you've closed the wound, then we will normally use an incisional VAC. So we'll put a VAC on a closed wound, and we believe that that has really helped our wounds in danger. So we would use an incisional VAC, a VAC on top of a closed wound, but we wouldn't put a VAC inside the wound, and we certainly wouldn't have put a VAC on hoping that the wound would miraculously stop draining.
Fabrice, maybe your last thought on use of resorbable or non-resorbable or nothing material?
Resorbable, or like Lee said, if you have a total filler and you can't use a silver coated one, or you can change the piece, because as Lee said, it's quite expensive, then yes, use a cement with 4 grams of vancomycin per pack, and you have a huge amount of antibiotics locally. Now I wanted to ask you a question on, generally speaking, for when you do a DARE on a megaprosthesis, for how long would you recommend antibiotics, general antibiotics? At least 3 months, but I agree in some cases we can go up to 6 months. We used to do 6 weeks, now we do 3 months. Do you agree with this?
In normal prosthesis, 3 months, absolutely yes. In this case, where a failure would be a disaster, I would go for 6 months.
Okay.
And if I cannot, for example, this would be ciprofloxacin resistant Enterobacter, I would go for suppression with cotrimoxazole for 1 year or longer. So Pakamani, if you can send us the antibiogram by email, we can give you then exactly the duration, the dose, and the choice of antibiotics. But rather over treatment than under treatment. Excellent, great discussion.
Thank you.
Thank you for all. And I think, Fabrice, you have prepared another case for discussion. So Pakamani, greetings to South Africa, and hope to see you soon again.
Thank you, Prof.
Thank you.
Fabrice, your case is now.
Okay.
Exactly.
Okay. So this is a big patient, 60-year-old lady, and she had bariatric surgery in 2012. She was at that time 135 kilograms, and she lost weight but she had still a BMI of 45 when she had this fracture of her right proximal femur. Of course, she has diabetes and she had renal impairment. She was not on dialysis when she had the fracture, but very close to it. So this is my first question. I think I couldn't read. What would you do? So no operation, osteosynthesis with a plate, a nail, a long gamma nail, for example, a prosthesis or other. So a lot of people do nails, some do plate. She is really, really obese. She has a morbid obesity. So osteosynthesis with nail goes first. Prosthesis. Okay, I think it's okay. So so we did what the majority of people chose. We did a nail. So technically quite difficult, of course. And so this is the postoperative X-ray, which looks good. I looked in the notes, and we don't have a real proper lateral view. And a month later, this is how it is. So she can't walk, of course. And now I could have both. So we did a revision, of course, and we did this total hip arthroplasty. 2 months later, she develops fever. The CRP is 325. We do a hip aspiration, and the blood culture as well found an RMSEA. So what would you do? Acute infection, would you do a DARE? Would you do a 1-stage surgery? Would you do a 2-stage? Would you do suppression? So majority of people do a 2-stage surgery. It's an acute infection. She has a BMI of 45. And so, well, we chose a DARE, but she wasn't fit for surgery. So we just gave antibiotics, waiting for the time that she would be fit for a DARE. Of course, the more we wait, the more the DARE becomes impossible to do, because far away from the start of the infection. And so it was a Saturday morning, and she's doing very bad with fever at 39, 40 degrees. She has an acute sepsis, not controlled. CRP is 100 milligram per liter. There is pus oozing from scar. She's now in dialysis, and so the infection is now chronic. And so the guys on call had to take her to the operating theater. So what would you do? There we had planned 2 months before, 1-stage procedure, 2-stage procedure, suppression, other. So majority of people would do a 2-stage. So this is what my colleagues did. They did a 2-stage. When they did the surgery, the bone was virtually non-existent. It was a sponge with pus. And so they had to remove all the greater trochanter and the lateral part of the femur, which was oozing with pus. It was a terrible infection. And so we end up with this spacer with vancomycin. My colleague did a sort of shelf to prevent dislocation because, you know, she's obese, so the risk of dislocation was very important. This is what the germs we had, the Staphylococcus capitis, Amaracea, and E. coli. This was adapted, and she had the rifampicin and Bactrim for 3 months. At that time, she was in dialysis. And a month later, she dislocated her spacer. So what would you do at this time? Reduction of the spacer, a new spacer, second stage, or something else. So a new spacer for most of the people. Okay, so I didn't want to do a new spacer. We decided to do the second stage at that time. So new debridement, new samples. I did the silver-coated proximal femur with a retentive cup in order to try to prevent any dislocation. Vancomycin, so general antibiotics post-op. And of course, the samples found a new germ, which was a multi-resistant bacteria, Enterococcus faecalis. So antibiotic was adapted with ertapenem, cotrimoxazole, and naflaxicin, confinement, and of course, she was still on dialysis. So a month later, we do some new X-ray because she was a bit painful. Dislocation of the prosthesis. What would you do? Reduction of the prosthesis. You do it there, changing the mobile parts. Do one stage, so change everything. Do a two stage again, or other solution. So a lot of people would do it there. Okay. So there. So I did a little bit more than a dare. I revised the cup because with this kind of cup, once you have a dislocation, the mechanism doesn't work very well. So I wanted to change the cup. So I revised the cup and put some reinforcement ring and change all the mobile part with the new silver-coated proximal femur. I didn't change the stem, which was cemented and which was strong and solid. Outcome was a disaster because she ended up with a renal failure, multi-organ failure, septicemia, and she died. So clearly, it was a bit of a disaster. So we just a few slides. So we all know that obese patients, especially with morbid obesity, that you have a higher risk of deep infection, dislocation, failure fixation, poor functional score, of course, multi-organ failure, and death. So there was this study showing that the higher risk of complication. If you have a morbid obesity, you increase your risk for a TKA by 32-fold, and for a THA by 9-fold. So this is something to consider. Infection for TKA, you have 10 times a higher risk. For a THA, 5 times. And so you have to take precautions, especially nutritional evaluation. If you have time, she had a fracture, so it's complicated. You have to check albumin, vitamin D, iron. And so the take-home for obese patients is take precautions to delay surgery if you can. Of course, if you have a tumor, if you have a fracture, if you have infection, it's difficult. Have a nutritional evaluation and inform the patient, inform the risk. Clearly, there are high risk, and you really need to talk to your patients. Thank you.
Yeah, thank you, Fabrice, for this case with not the best outcome, but that's exactly why we want to discuss it here.
Yeah.
It was a really difficult situation. You had first an acute infection, then a chronic infection. It was a mixed infection, which is already a risk factor for bad outcome. and in addition, all the risk factors from the patient side. And I like the slide where you mentioned that we should optimize the patient.
Yeah.
And we discussed before how we could improve also the perioperative prophylaxis. I think for this patient, and you mentioned here 9 times or 10 times larger risk of infection, I would really go for the maximal prophylaxis. Maybe increasing the spectrum is better than prolonging the treatment. So instead of cefazolin, in this case, I would go for example for Tazobac, so which is piperacillin and tazobactam, plus maybe even vancomycin, because you have nothing to lose in this case. There is no camera, I see, from my side.
Yeah, and we have lost Volker.
Volker, yeah. But maybe we can discuss
yes,
it, yeah?
Maybe we could ask my colleagues from the faculty. Lee, in the first stage, would you have operated this patient? Would you have done a nail or maybe a prosthesis? Because maybe a good prosthesis would have prevented the complication. You know,
So
like get it right first. So clearly,
Yeah.
osteosynthesis in this kind of patient is not easy, because it's not easy to do. You know that the lateral view, I think, was not good the first time. That's why we got the displacement. So
I think as with tumours, I think as you know, in UK we have a big drive to get it right first time, and there's a lot of pressure to fix a fracture in 24 hours or 48 hours. There's a lot of pressure to do a DARE in the first 24 hours. But actually having the right team to do the right operation, I think, is the most important thing. So I think if people had gone back and considered the case a very high risk patient, if they consider the case a very high risk patient with very high risk of complications, done by somebody who does a lot of infection work and a lot of complex arthroplasty work, that maybe an arthroplasty in day one and had one operation that was perhaps more reliable, may have prevented the problems that the patient subsequently had. And I think there's you showed a very good example of a Saturday morning with a failure, with an infection done by a non-infection team or experts that could have easily waited till Monday or Tuesday when the right team for the job, including microbiology advice, infectious control advice, optimizing the patient as much as possible, may have improved the outcome. It may not have, but it may have improved the outcome.
What about the Girdlestone situation? In the chat, there were many questions about that. One favorizing it, the others saying that this is a disaster in obese patient. Fabrice, what is your comment on that?
yes, I think that the fact that, you know, the team on call operated that lady in the emergency, they removed the prosthesis, and there is pus, we do big spacer. I don't know, maybe removing the prosthesis and no spacer could have been an option, absolutely, a Girdlestone, or do a DARE. This was emergency, even if we were two months from the start of the infection. Do a DARE and then think. The fact that she had a big bone resection, with a big spacer,
yeah.
this is where it went wrong.
And you create a dead space.
With patients, you have to be careful and think. So I agree with Lee, this emergency decision, you know, could have been.
I think there's also a great, if the patient was very unwell, which they were septic and they were poorly, and it's a life-threatening procedure, then I don't think there's any problem with decompressing the infection like you would an abscess and simply opening the wound and washing it. And this is the emergency procedure, and then the cure of the infection comes later, because we all know that removing the bone is the easy bit. It's the soft tissue debridement, which is the difficult bit. And that's the thing that's going to, we've talked a lot about it in the previous meetings and webinars. So I think there's nothing wrong with the emergency team going in and opening the wound and letting all the pus out and irrigating it. But knowing that they haven't treated the infection, they've decompressed it, and then letting the infection team go back in, 2 days later when the situation is under control from a medical point of view, and then dealing with the infection definitively.
So Lee, what you mentioned now is the solution to pollution is dilution of bacteria. So opening, washing out, that's the first thing to prevent a septic shock. And there was a question regarding also renal failure. That was probably septically acute renal failure. And the question was regarding antibiotics. I think there is no concern. If you have a septic patient, even that the kidney is completely failed, you just give as fast as possible the first shot, you have nothing to lose. Of course, later on, we adapt it to the function, but the first dose is always the full dose. Volker, you had some difficulties, I heard. So
yes, the link ran out, and I got a new link, and now it's working. Hopefully.
Is anything you want to comment for this case, or maybe?
Yes, I think that the mortality for this patient after the infection of the prosthesis was already very, very high. We also know this from geriatric patient, and although your patient was not so old, it was with all she was with all her comorbidities. She was a kind of fragile patient. And we know that in the hip fracture patients, when they receive a treatment, and either let it be a fracture fixation or synthesis or even a hemiarthroplasty, when they get infected, they have a mortality risk of 60 up to 70% within 1 year. And this is the challenge in those cases, because you have a fracture patient, which is a fragile patient, and he has an implant, and if this gets infected, we've got 2 or even 3 problems. You have a fragile patient, you have an implant in it, and this is infected. And the combination of these 3 issues makes a very, very high mortality rate. And this is not a kind of acute infection after a knee prosthesis in a healthy patient where you can do a DARE with a success rate of 90%. This is really life-threatening for those patients. That's a very difficult situation, although the implant looks pretty small.
Thank you. Yeah, thank you for that comment. I think we can go to the next case. Fabrice, thank you very much. Lee, you prepared one interesting case, single or 2-stage exchange. Please.
Yes. So I want to bring up the usual question about whether we should do single stage or 2-stage. So we know that antibiotics can't save inadequate surgery, and it's becoming more and more clear that, as we found in the last case, that the outcomes and the mortality from periprosthetic joint infection, this is a slide from J. Parvizi, is higher than most common cancers, with about a 25% or worse mortality. And if we look at the UK outcomes for survival from cancer, if we were to put periprosthetic joint infection as a cancer, it would be up towards the top in terms of 5-year survival. So my life is treating these cancer patients, but also treating these infections. And we used to have a relatively standardized care for patients. So if it was an acute onset, good skin, sensitive organism, good host, we would go for a DARE. If it was a chronic patient but it had a sensitive organism and good skin, it was a good host, we would do a single stage. And if it was a bad chronic infection or a resistant organism or a poor host, we would do a 2-stage. But this lady will always stay in my mind as a lady that died during Christmas, having not made her second stage operation from what would have been a relatively straightforward infection to treat as a single stage. And we know that the survival for patients after 2 stages is looks good at 89%, but at 10 years is only 54%. But what we don't show in the same paper was that 20% of patients in this series never got to their second stage operation, and therefore the real figures were much lower. So it's a bit of an unfair fight, really. How far do we go to get that extra 5 or 10% chance of improving survival? So perhaps sometimes we need to take a different approach. So I want to show you a case where maybe we should think about being more radical with the elderly or unfit patients. And I'd like to sort of make you think about perhaps a strategy where we do radical operations in the worst patients, because these patients are the people that are least likely to survive their infection, or certainly least likely to survive 10 years. So we started treating recurrent infection or bad infections with very radical debridements, including the bone and the soft tissues, and then giving them a stable reconstruction. So I'd like to present a case of an 81-year-old gentleman who was diabetic, who'd had a complex primary knee replacement 6 years previously, and then presented to another hospital very close to us in the city with an acute infection. CRP was 40, temperature was 38. And unfortunately, this type of prosthesis is no longer manufactured, so there wasn't any polyethylene that could be done, but it's also an implant which is very difficult to remove because there's no access to the tibial component from the knee joint. So the patient, as an emergency, was started on antibiotics prior to the surgery. And then they attempted to do a DARE, but they didn't have any polyethylene. So they simply took out the polyethylene and they put in a very small amount of antibiotics, not into a very useful place, and discharged the patient home after their acute operation on 2 weeks worth of antibiotics. Eventually, the local doctor saw the patient and he referred them to my clinic, my infection clinic, and I saw the patient 2 days before Christmas with these x-rays. The patient was an elderly gentleman and he wasn't very well kept. You can see that he presents with an abscess over the outer aspect, lateral aspect of his knee, and you can see from his trousers that he wasn't wearing any dressings. His trousers were covered in chronic pus and exudate. So this is clearly a gentleman that doesn't particularly look after himself very well. We managed to get the aspirate result from the previous hospital, which showed that it was a sensitive streptococcus. So we've got a sensitive organism, but an abscess in a poorly gentleman. So I'd like the audience to think about this case and think about what should we do as our treatment for this gentleman. Should we do a single stage revision to a hinged knee replacement, a single stage revision to a distal femur, a two-stage revision with a flap? Oh, I think we've gone back to somebody else's survey. There we go. So should we do a single stage revision to a hinge, single stage revision to a distal femur, two-stage revision with a flap at his first stage, or should we just offer him an amputation? Okay, so we're starting to get a consensus then. So the majority of people would go for a two-stage revision, either with or without a flap. And this is, of course, is the standard treatment. That's what we would recommend to these people. So he came 2 days before Christmas. I took him to theatre on Christmas Eve, the day afterwards, and we decided to do a single stage revision to a distal femoral replacement, silver coated, with a cone to reconstruct the defect and get the joint line in the right position. You can see here that we didn't do a flap at this stage, though we routinely do flaps. But once we debrided it, we were able to close the skin quite nicely. As you can see, this is a few years ago. I think now I would have added in some local antibiotics. More worryingly, this level of osteomyelitis that we all assumed was infection, when we got the histology back, and it's important that we always send histology with the microbiology, turned out to be myeloma. So even we didn't expect that to be myeloma, but may account for his condition. So here's his X-rays. I'm sorry if the screen is a little bit blurred, but you can see that on the 25th, on Christmas Day, the day after he presented, his albumin was very low. And I think this again brings a point about how infection depletes you. But as his infection got better, you can see that his albumin starts to rise, and that his HB starts to rise, and his platelets start to come down. We can see that his CRP started to normalize quite quickly, and by 6 weeks after the operation, he was on normal CRP. So we were quite pleased with ourselves. The chap comes to clinic. This is his sinus that has all healed up nicely. He's got very good function. He now has clean trousers and has started to put on a bit of weight. Almost a year to the day he presented, and I got a call and said, "Oh, this chap's back again. He's got an infection." And I was like, "Oh my God, it's all gone wrong. We should have done a two-stage revision." But it wasn't the left knee that we did that was infected. It was his right knee. And this was difficulty weight bearing. CRP was 105. He's got a permanent catheter now. And again, he'd already been started on antibiotics by the hospital, which takes the acute cases by us. We aspirated his knee, but he was already on antibiotics. And we now got 2 staphylococci epidermidis, but a very resistant biogram, only sensitive to vancomycin and daptomycin. And so a highly resistant antibiotic. By this time, he's lived a year. We've still got no polyethylene. So I thought, oh, perhaps we should do a 2-stage revision because of his resistant organism. So we did a 2-stage revision. We removed all his implants, put in quite a nice spacer. He did pretty well. We didn't grow any antibiotics organisms from his surgery because of his previous antibiotics, presumably. But his 16S rDNA that we send off if we don't get any positive cultures came back with a strep pneumoniae and a strep mitis. So probably strep pneumoniae was the more important. So now I just want to show you his blood test. So this was at the time after his surgery. Remember, we operated end of November. We got his infection down, but now you can see that his infection markers, his CRP, start to rise and then start to rise quite dramatically. If we look at his blood tests again, we can see that his HB starts to drop again. His platelets start to drop to a critical level here, and now he's starting to develop renal failure as well. And unfortunately, the gentleman died 2 months after presenting with his first stage revision. And I'll always wonder whether if we'd done a 2-stage revision, whether we would have, single-stage revision, whether we would have helped him. So We're just about to publish our results for single-stage revisions with distal femurs for infections. And in this group, which has quite a high rate of multi-drug resistant organisms, we're able to clear the infection in 80% of cases. This is our result for ordinary knee replacement. So what we do for most patients works pretty well in most cases. But I think we should think very carefully how far we should go to get those 5 or 10% perhaps better results. And perhaps we should be thinking about doing radical surgery for the worst patients. Thanks very much.
Excellent. Lee, thank you also to pointing it out that two-stage is not always the best solution. And you showed nicely how the patients were getting worse and worse. The kidney failed, the CRP was rising. So if we optimize the local antibiotics, systemic antibiotics, and do it in one stage, maybe that is better. Volker, I see that you also said yes. So, or what is your opinion on that?
I like the idea of the one-shot surgery for the critical patients, because as Lee pointed out, many of those patients, they do not survive a two-stage procedure, or they do not get really their prosthesis with the second surgery. And we have to remember that this interim interval without having a good joint, without having a functional joint, with a two-stage procedure, this is very, very demanding for those patients, and they are very, very sick. And this interim interval after having their prosthesis removed, this is very difficult and makes them even sicker, and mortality rate will also be affected with that. So I really like the idea, and we do that too. For very, very critical patients, we do a large tumor resection, and we put in a big prosthesis to have a good control of the infection and to keep the surgery to one intervention. An interesting aspect, Lee, with this case is the fact that the patient had 2 knee prostheses.
Yeah.
So there's always the case when we see patients nowadays, they have one infected hip on the right side, but they do have a hip on the left side, and they also have two knee prostheses. The patient says, okay, 2 of the 3 additional joints work well, but there is one that hasn't been working well for quite a while. How do you deal with other total joints after having confirmation of one infected joint?
Yeah, so I think that's a very good question, and I think Andre would be happy to know that we kept that guy on antibiotics for 6 months afterwards. So I think we need to, what we try to do is, even if the other joints aren't symptomatic, while we're doing the other case, we'll often aspirate the other joints. So first of all, prove out there's only one joint that's infected. Obviously done it, in a way that's safe not to introduce infection. And then I think extended antibiotics to prophylactically help the other joints to prevent becoming infected. So this guy's immunocompromised, he's got myeloma, he's going to go on to chemotherapy, and his chances of the other joint, he's a very unwell gentleman. But the reason why I put the blood tests up is that we're orthopedic surgeons, but we don't often look at the things that the infection doctors look at, which shows our soft markers of how the patient is doing. I think that the albumin, I think the platelets, and I think that the hemoglobin often tell us that this patient is getting better or getting worse, whereas we tend to fixate on the CRP. And I think we have to think about a bit more like a physician about other markers of what the body's doing.
Considering also the host, and that's also the classification, Volker, you presented to include
Absolutely.
Also not only the bacteria and the implant, but also the host.
That's what I try to say. If you have a really fragile patient, a really sick patient with a lot of comorbidities, we try to capture that with the classification, with the M between the M0, which is a healthy patient, and an M3 patient, which is a patient that's very, very sick and that does not tolerate surgery or anesthesia.
So I think my point is from the case and the way that we try to deal with patients in Birmingham is how far should we go? We showed our figures. We have a 90% chance in an ordinary hip or knee replacement of curing the infection, so we do that okay. But if we have an 80% chance of being very radical with a very unwell patient, how far should we go to get that extra 10%? Because the chances are that patient is not going to be alive in 5 years or 10 years. They may not even be alive in 1 year. So should we push the boat out to get that extra 5 or 10%, or should we be pragmatic and think that we'll get this chap back up on his feet as quick as we can, allow him to get home, and then maybe we may have 80% chance rather than 90% chance curing the infection, but at least he's got a limb in there that's going to work.
Fabrice, what is your thought on that? And maybe
I completely agree with Lee. Get it right the first time. Do one stage. Generally talking, in a general orthopedic surgery, when we see the result of the 2-stage, of course, the patients who died between stage 1 and stage 2, they are not in the final success rate.
They never get counted.
Of course, and the people who do not get their 2nd stage because they were too ill, because they couldn't make it, they are not in the final success rate. So we end up with a fantastic 85% success in 2-stage with 10% mortality, which is not said. We reviewed our cases. I was a big 2-stage guy. Now I am a 1-stage guy, and I do a 2-stage when there is a contraindication of 1-stage, which clearly very rarely happen. A fistula is not contraindication. Maybe a fungus. But so I need. I totally agree with Lee. This poor patient is bad host. 1-stage. Get it right first.
And Fabrice, what do you think about in Lee's case to use arthrodesis? So arthrodesis nail.
Use arthrodesis prosthesis.
Yes.
If silver coated, well, and if the case is too bad, if you don't have any more extension, basically. Otherwise, I would try to do total knee arthroplasty or distal femur.
And that was probably Lee your also strategy, right?
Always silver coated. Always silver coated.
So I think the question today is to talk about again about megaprosthesis. So we've shown a case, but the point is the debridement extends to the bone as well, and you could see on the initial X-rays that they had that big lucency above an uncemented implant. Now that turned out to be myeloma, but if it hadn't turned out to be myeloma and it was a pocket of infection in there, then we believe if there's periosteal reaction that we should excise that bone if we're going to be radical, you know. And I think that's the point. Is it's about debriding everywhere where the infection is, because in a 1-stage revision you've got one shot, you know. And so that's why we choose to do a distal femur replacement in those cases.
And we can say the one shot, despite it seems for this critically ill patients is maybe a better choice, but it really demands the best possible surgical team, because if you do many mistakes in 1-stage, it can be even worse then, because then you have a worse situation with a second stage, 2-stage procedure.
But I think, again, it shows the things that we've highlighted earlier in the meeting, that it went to an acute hospital, so it was managed by an acute team, whereas perhaps it would have been better to say, okay, let's just debride them. I was quite interested to talk a little bit about from an infectious disease point of view. Do you use 16S rDNA if you get a culture negative case, or?
And We do it, but have not good results. Often we find some bacteria which are probably contaminants.
Yeah.
So we treat them empirically for culture negative infections and cover gram-positive and gram-negative and have better success than searching for something which is difficult to find. 16S is not as sensitive as it should be because there are many inhibitors and other factors.
So I wanted to make a point on the early cases. I think you made a very good point, Andre. If we don't know what the organism is, we should always cover with our local antibiotics for both gram-negatives and gram-positives, is the first thing. And in cases like Fabrice's case, where or the case we saw from South Africa, where you've got a chronic wound and stuff like that, if the patient's very poor, we will always cover for fungus as well, because it's only 2% of our cases, but it happens in the worst cases, So I think if you don't know what it is, then there's not much harm by covering with your local antibiotics for most things, for fungus, gram-positive and gram-negative.
I think as soon as we put metal in our patient, we should use broad spectrum antibiotics. Remember that in 2-stage, when you do your sample at the 2nd stage, in a lot of cases, you find different bugs that you don't know.
Yeah.
So you have to cover these bugs as well.
Yeah, very good points. I think today is, I can say, at least from my view, our best online seminar, because we are discussing things which you will never find in an article. And I especially appreciate both Fabrice and Lee that you presented failed cases, even death cases, which you usually don't discuss on conferences. So really thank you for that. And I think our aim, how we can be better, we achieved now with these cases. So for the last case, Volker, you prepared one interesting case, so it's your stage.
Yes, I have one more failure. This is an infected distal humerus replacement with a soft tissue defect that I would like to present. So this is a 70-year-old gentleman who had an implantation of the distal humerus for leiomyosarcoma. 1 year before I saw him, he presented like this in my outpatient clinic. You see that the mirror sign, so that the surgeon can see himself reflecting his face here on the prosthesis. So this was the situation, and we tried to discuss those cases in an interdisciplinary extremity board, how we call it. So we have colleagues also from plastic surgery, which is important for such a case. Also for a lot of patients with expertise from the vascular surgery department. But we also have colleagues from microbiology, pathology, and radiology just for the diagnosis. And we have certainly colleagues from infectious disease and also internal medicine to discuss potential antibiotic options. We do the case analysis and discuss it, and then we go either for further diagnosis or for the treatment plan. Just to show you that we try to live this interdisciplinary concept in order to give those patients interdisciplinary approach. So this is the X-ray of the right elbow. You can see here that distal humerus replacement was cemented. You see that the cement goes all the way up the shaft of the humerus. The wound is approximately here, and this is the situation. So all soft tissues defects go along with a chronically infected situation. I think this is for sure. It's a polymicrobial infection of the prosthesis, and the patient was in a lot of pain, and he wanted to have a definitive solution for this problem. So even in this case, I think we could discuss a single stage approach with a plastic surgery coverage of the wound, and also a one-stage removal of the distal humerus prosthesis, which I did not there in that situation. I recommended the patient a two-stage procedure, which we then did. So the first procedure was a pedicled latissimus dorsi flap for the wound with a removal of the distal humerus, and I put in PMMA loaded spacer. And this was then the situation directly after surgery. You see that pedicled latissimus dorsi flap with full soft tissue, full skin coverage here. The rest of the flap was covered with a split skin graft. Put in a fixator to give him some external stability. And this is the X-ray with the removal of the prosthesis. You see that I put in here the antibiotic beads in the intramedullary canal of the humerus. And this is the placement of the external fixator. So we detected some stuff epi, although we knew that this was a polymicrobial infection, and therefore we did a broad antibiotic therapy with flucloxacillin against the stuff epi, and also meropenem for the gram-negatives, and then switched to oral clindamycin according to our infectious disease specialists. This is then 2 months after removal of the prosthesis, and I told the patient that after 6 weeks he might have a chance to get the new prosthesis. But as in these cases, not all complications can be foreseen. In this case, he developed wound healing disturbance here at the distal part of the flap, and you can see this even more clearly here. So the skin and the flap got lost here, and he had a soft tissue problem, for which he then was revised once again from our colleagues from plastic surgery. They did cover that wound again, and this was then the situation already 3 months after removal of the prosthesis. This was 2 days after that soft tissue revision. And fortunately, the flap and the soft tissues healed, and this is the situation 5 months after the second revision. But you can also see here 5 months. So what happened in those 5 months? Once again, the wound healed, the fixator was stable, and the patient, he was doing very fine with the arm. He was pain-free. But the thing was that in the meantime, he developed metastatic disease in the lung and also in his skull. And now the situation is that he is in treatment with the colleagues from oncology. So he's on chemotherapy right now. This is the X-rays 9 months after the removal of the prosthesis. He wanted to get rid of the fixator at that time. I removed the fixator. So this is the situation right now. You still see the PMMA spacer and the PMMA loaded antibiotic beads in his humeral shaft. He has a splint. He gets very well along with that splint, but this is the situation. This patient might up in a situation that he will not receive a prosthesis anymore, because also his metastatic disease will limit his life expectancy. And this is also a case which is a difficult to treat case from a surgical point of view, due to the soft tissue defect, but also from his overall health conditions with his metastatic disease. And the conclusion for me is, in such cases, soft tissue defects can create even more problems. We try to manage that with the interdisciplinary team. And oncology comorbidities can create even more problems. And we need to be prepared not only for our plan A, we need to be prepared for plan B, for plan C, and even for plan D. And we need to take good care of these patients. And I think this is, at least for me, what I have learned during those 4 webinars, that we have to deal with very special patients with very special situations, and we really need to do our very best to take good care of those patients. Thank you very much.
Thank you, Volker. It couldn't be a better conclusion than this, your last slide. And we have a couple of minutes to discuss also your complex case. Is there, Lee, would you like to comment?
So I think we need to think very carefully about what the definition of success is. For an orthopedic surgeon, a definition of success is getting another implant into the patient. Yeah. The definition of success for that gentleman is that he's kept his arm, he's got a functional hand, he can use it well. That for me is not a failure. I think we measure failure too frequently by whether we get another implant in and whether the infection has been eradicated. But a well-functioning limb, which is useful to the patient, which is not painful, which is better than you started with, is, for me, is a definition of success. So I think you've done excellently with that patient, and I'm sure that they'll be eternally grateful for your input.
Yes, I completely agree that success needs to define alternatively for such cases. Every time when he comes back to my outpatient clinic, he's grateful because he's pain-free, and he was in a lot of pain with his soft tissue defect. And although I didn't promise him to get the new prosthesis right from the beginning, but my hope was to get, after 4 or 6 weeks after the soft tissue defect had been controlled, to get the new prosthesis in. Even as you said, he still had a good hand function. He is right-handed. He can use his hand for eating, for writing, and so on. And he could keep a certain quality of life with that limb, although he did not have a new prosthesis.
So we have completely new definition of success, even from infectious disease standpoint. If the patient is pain-free and functional, he doesn't need to be infection-free, because infection we can very well suppress. And that's also our aim.
I was very keen to do a research project about this shared decision making. So it's quite popular in lots of other aspects of medicine now. When we start at the beginning and say to the patient, what is it that you would like from the procedure? Where do you want to be? And what can I achieve? And we agree that we're going to try to avoid an amputation, or we're going to try to do whatever it is that we decide between us, because that's the real definition of success, when the patient's happy and the treating team is happy. And it's not always what we think is the obvious thing.
Fabrice, your last thought?
Yeah, just one question, Volker. So in your plan, the first stage, you remove everything, put the flap, and then you have the external fixator. Do you have experience of second stage with the external fixator being on the patient for, I don't know, 6 weeks, 2 months, 3 months? And I don't feel confident to do a second stage with a prosthesis, with stems, you know, when an external fixator has been in.
Good question, Fabrice. I would have given him a pin holiday. So I would have removed the fixator, and I would have put the limb into a splint for like 2 to 3 weeks to get the incisions healed, and then go for the prosthesis. I would not have done the prosthesis directly with the indwelling fixator.
Thank you all for the excellent discussion. It was really a pleasure. And also thank you for everybody listening to us, including the 2 presenters from other countries. Hope to see you soon again. and from this stage, goodbye from our side. Lilith, we have the last slides. Yes, the closure. So we have the fourth of the 4 webinars, and as I mentioned, we will probably have next year on-site workshops and also future online seminars. If you have a complex case, you can upload it on the consultation portal of the PRO-IMPLANT Foundation. To get more information, please contact this email. And we have now soon running special online seminar on fracture-related infection, started on December 10th. And with this, I can just say thank you, everybody, and especially the technical support behind the scenes, and also to you. I should not forget, if you want to see any recordings from the first 3 web online seminars, you can watch it, the link you will get. And please, after this finishing, give us your feedback so we can be in the future even better than today. Thank you very much, and goodbye.